are here getting ready for our next session with Dr. Ben Locke from Togetherall. Um, so I would say, Dr. Locke, you can begin sharing your screen, and that way we can get started right on time.
Sounds good. Can you hear me okay?
Yep, coming in loud and clear.
One change to my microphone, still okay?
Yep, you are good.
Great. Okay, here comes the share.
You can see everything. Okay, so I would say go ahead and begin when you are ready.
Right. Thank you. And hello, everybody. Good to be with you today. I'm just pulling up the chat and other screens so I can see everybody. So my name is Ben Locke. I'm going to be talking with you today about the critical role of population-based services in delivering mental health support to those in need. And really thrilled to be with you today, talking about wraparound services, talking about mental health strategies in higher education. I know we have about 15 minutes of Q&A reserved at the end, but feel free to put questions in the chat as we go, and I'm happy to respond questions or clarification as we go along. So that's me, same guy in the picture and in the video. That's good. Just a quick outline of what we'll be doing here. So I'm going to do a quick intro, talk a little bit about my kind of professional transitions. I was in higher ed for about 20 years, transitioned over to Togetherall. And so we'll talk a little bit about that because I think it has some parallels and provides some context for what we're talking about today in the broader conference and higher education. I'm going to talk specifically about supply and demand for clinical services, mental health services in higher education, try to provide some context there. We're going to talk about the real importance of having strategies for attending to mental health services in higher education as opposed to solutions. And we'll get into why that matters a little bit. Talk about the concept of population support, and then I'll tell you a little bit about Togetherall, what we do, and the team that I oversee on the clinical side. And then, of course, we'll have some Q&A. So this, by the way, for those of you planning your next adventure, this is in Canyonlands, this image, which is pretty near Moab in Utah. And this is a trail called the White Rim Road. And you can see it running along the cliff there. Then it goes down the side of the butte, down into the valley. So amazing experience. And so I've often thought of this image when I think about transitions in life. Most of this drive down this hill was myself and my partner and our two kids and or three kids at the time. And Deanna was saying all the way down this road, slow down on every corner. And sometimes we can't slow down during transitions, but it's important to sort of embrace the journey and embrace the challenge. So I spent about 2 decades working in college student mental health, specifically in college and university counseling centers. I played all different kinds of roles there, clinician, leading services, researching services, working on the front lines. I'm a psychologist by training, and so I trained in one-to-one services and counseling. And over the course of those 20 years, one of the things I worked on building was something called the Center for Collegiate Mental Health at Penn State University. So CCMH, I'm going to talk a little bit about it as we go today, and it will provide some important context. One of the things that this 2 decades really showed to me was the emergence of the demand supply challenge in higher education, specifically focused on clinical services, the one-to-one counselor to client demand supply crisis. And it's a very real challenge that everybody is coping with. And the research I was doing with CCMH, which today represents about 860 colleges and universities, increasingly made it clear to me that there is no magic solution to staffing of college and university counseling centers. It's just strategies, and we'll dive into the detail there a little bit as we go. Um, and over the course of several years of coming to terms with this demand supply crisis, there is no path in the near future where there are enough graduate programs and enough seats in those programs to produce enough counselors to meet the demand. And because of this and the costs and expenses of delivering services, it really made me start to think that we needed to build the next generations of mental health services and supports at a population level. So that's a little bit about my transition. The good news is that Deanna and I and our three kids made it safely to the bottom of the canyon and enjoyed the ride. And I think that the challenges and changes we're facing in mental health are going to require a similar kind of long distance um, uh, sort of time scale and persistence along the way. So just looking back really quickly, sometimes we all assume that the demand supply challenge that we see has always been there, but it actually hasn't. So even when I started in college and university counseling, my first experience was in 1997. A lot of schools at that time were doing outreach into the community and trying to convince people to seek care. Today, colleges and universities are generally doing outreach to convince people that they're okay and you don't necessarily need to come in for services. And here's all the other things that you can do. So over 20 years of national and international interventions and funding for those interventions at private, state, federal levels, even like you can look at the Garrett Lee Smith Memorial Act at the US federal government, which has pumped hundreds and hundreds and hundreds of millions of dollars into these efforts. It's taken on three major forms: reduce stigma, which is the negative feelings people have, the worries they have about seeking care; increase their actual help seeking behavior, their willingness to go out and engage in help seeking systems; and then train the community to identify people in need and get them into services. So this is more than 2 decades boiled down into three major initiatives. The basic narrative that emerged out of all of this is, if you're in distress, go see a professional. And what we've experienced as a field, anybody working in higher ed, anybody working in mental health and wellness, is the explosion in professional demand for professionals from this identify and refer model, which nobody really set out to create. It sort of evolved as a consequence of all these efforts. Of course, the key problem is there is no there's not enough supply to meet this demand, and there's no clear fix ahead. So that's kind of how we got where we are. To just visualize this a little bit, if you think about, I'm going to talk a little bit about counseling centers and counseling center staffing, sort of one-to-one clinical services, then we're going to transition into population. Sometimes people talk about mental health services in higher education as if they are a monolith, as if they're all the same. And the reality is that the percentage of the student body at any given institution that uses the counseling center in 1 year ranges really widely. At one point in time, I think I saw the maximum utilization at about 60% of the student body per year. This was pre-COVID. I think now it's more in the about 40%. But there's lots of schools out there that have a utilization that's very, very low, even around 1% or less of the student body. And the average tends to be about 10%. I think this year it might be 11%, or last year it was about 11%. And of course, you can contrast those with who might benefit from a mental health service. Could be 100%. So to bring a couple of these data points together, let's just kind of walk you through this slide to illustrate the maths, if you will, behind the problem we're experiencing. From a population standpoint and a basic needs standpoint, we know that potentially everybody at an institution could benefit from support, mental health support, not necessarily treatment, but support. Healthy Minds in 2022 found that about 60% of the student body screens positive for a mental health concern. Now, whether you agree or not with that methodology and the way they achieved it, this was the result. And if we look at the treatment capacity of a counseling center, somewhere between 1%, let's say 40%, more updated number, that capacity is going to range. And then depending on where you land on that utilization spectrum, you're going to end up with a treatment gap. So let's say you're an average counseling center at 11% of the student body utilizing per year. This was data from the Association of University and College Counseling Center Directors last year. Let's say you're average and that the actual need is about 60%, then you have a treatment gap of about 49%. Of course, if you increase your utilization of your counseling center to 20%, you still have a treatment gap of about 40%. And so the point here, and by the way, doubling the capacity of a counseling operation is very expensive capital and human expense challenge. So the fact is that we really do need a both and approach to mental health and higher education, kind of a wraparound approach. But this idea that somehow we're going to meet all the need by staffing a counseling center is just not true. And I am a counseling center professional by training and background. That's what I did for more than 2 decades of my life. And so I don't say this lightly. I say it really with a lot of experience behind me that we really do need to think of a both and approach. So if you're at an average level of counseling center staffing and you say, okay, we're really going to fix things this year, we're going to add one more staff member, and that's where we're going to put our money, that will help, but it will not fix the treatment gap or the gap in people who potentially need support. So again, we're still talking about counseling center staffing for a minute, and then we're going to transition here into population support. If you're really interested in better understanding the staffing of counseling operations, direct one-to-one mental health services, no matter what kind of exact services they provide, I'm including on this slide a paper that I published along with a team at CCMH a couple of years ago that details about 6 years of work building something called the Clinical Load Index, or CLI. And this metric is now sort of the leading metric that's used for understanding the staffing of college and university counseling centers. And down here on this slide, you can see all these little dots, all these little dots down here with a blue dot in the middle. Every single one of those dots is an actual university, and it illustrates on that spectrum, that XY axis, the average annual caseload of a standardized counselor at that counseling center. So it could range from, let's say, about 20 clients per year, 20 students per year per counselor, or up to 250 students per year per counselor. And then in the middle, you have this big bunching of schools. But the point here is that as you move from one CLI, a low one, to the high one, the kinds of services provided, the experience of the student seeking service, the experience of the counselor providing service changes. And so this is a really good detailed online tool that you can go look at. I provided the link below. And again, the reason for this is just to the reason I'm sort of walking through this in some detail is to underscore that there's not a single solution for staffing of mental health services. There's a range of strategies, and all of the hundreds and hundreds of schools on this chart have a different strategy in place. And that simply adding another counselor, well, potentially a very good choice, doesn't necessarily solve the need. What really does matter, though, is this concept of alignment. So you could have any one of the strategies that these schools might have in place on this slide. What matters is whether or not everybody's aligned around the strategy you have in place. So you need to ask yourself, what's the mission of your institution? What are the resources you have available to use for mental health services? And then are all of the stakeholders who care about those services, are they aligned around the reality of the staffing and resources that are in place? When I was at Penn State University as the director there, overseeing 25 campuses and 100,000 students, I would often say to leadership, I can run a crisis and referral center, or I can run a center that provides treatment. Both are possible, but everybody needs to be on the same page. And that's the concept of alignment, is making sure that you're not promising one thing, but then actually delivering something else. Okay, so that's a bit of a dive into clinical services, direct clinical care, and understanding that, contextualizing that is important for the next step, which is about population services. So a population approach to student mental health has a number of characteristics to it that are related to direct care clinical services, but also distinct. So a population health approach to student health, again, is a both and. When you're talking about the treatment that we were just discussing in population, it's not either or, it's both and. But in population lingo, universal access. So every single person of your community should be able to access student mental health services, student mental health supports. They should be able to do that 24 hours a day, 7 days a week, should be in the palm of their hand, and it should be available to them in their moment of need, not necessarily the next available slot, which could be 2 or 3 weeks away in a traditional care setting. Even institutions that have a same-day access to services often still require, calling or going online, scheduling an appointment, showing up for the appointment, meeting with a person. That's not necessarily moment of need. Sometimes people just need a little support in this moment at 2 a.m, and then they're on their way. The services should be therapeutic in nature, supportive in nature, but not necessarily treatment based. They should absolutely include a crisis intervention, crisis support system in the back end. And the idea here is to scale natural support systems that exist in order to reach the broadest number of people possible. And if, from a financial standpoint, the key way to understand a population-based service from a treatment-based service is this. In a population health approach, every additional student that you send to the population service makes that service more cost-effective. In contrast, every new student you send to a treatment service either makes that treatment service more expensive because you need to hire more staff, or it dilutes the amount of service provided to per student seeking the service. And so this is the idea behind wraparound services at a population level. One of the phrases I often use is no wrong door. This is a philosophy of care where you design your strategy and your set of services so that no matter where a student enters, they get to where they need to be, but there's no judgment or pushback against the door they happen to walk into. And again, from a both and standpoint, when we think about the treatment gap, that even if you serve the average number of students or double the average number of students, you'll still have a huge treatment gap, support gap, that it makes sense to lead with a population health approach and then to scale your specialized services, your treatment services, based on your resources and your mission that all stakeholders kind of agree to. And that's why moving with a population-based approach kind of tips the scale on its head, because you're giving everybody access to basic needs support, and then being very strategic about how you're growing and implementing your direct care services, because they're often because they will be limited due to expense and implementation. The other thing that I would just kind of acknowledge is that over 20 years in leadership in higher ed and consulting with hundreds of institutions, is that this way of thinking helps to gives institutions and their leaders who are responsible for implementing these services permission to say, oh, we don't have to solve everything by just doing this, by just hiring more counselors. We can actually provide support to an entire population, do it well, do it effectively, change the help-seeking narrative on campus, and then still provide treatment at a level that fits with what we're capable of. But this mindset really gives you the ability to have a massive impact at a relatively small expense. Okay, so I'm going to transition now into talking a little bit about Togetherall, which is a 24/7 digital, clinically moderated peer support platform. In terms of my role at Togetherall, I'm the Chief Clinical Officer, and I oversee about 50 employees who are part of my clinical team, and they provide all the moderation on the platform. I just want to emphasize these are employees. They're salaried, they have benefits. They're all licensed and registered clinicians who live all over the world and work on the platform in the back end. And given that scale, it probably becomes clear that this is not a flash in the pan kind of project. Togetherall has been around for 18 years. We offer a true population health model to support the mental health of those using our community. So it's a safe, scalable online peer-to-peer mental health community. The students and members that use the platform engage anonymously on the platform, and that is enforced by my team because it removes all stigma to help seeking and allows people to focus on the mental health concern that they have, as opposed to who they are or where they are or what institution they're affiliated with. It also helps to make the online experience safe from bullying, trolling, doxing, and other kinds of abusive behavior. So it's available, of course, in all different sizes of digital, whether it's an iPad or a phone or a laptop or a desktop. And when we think about clinically moderated peer support, again, a population-based approach, it's accessible, number one, as we talked about early on. Immediate access, 24 hours a day, 7 days a week, mobile first. Wherever the student is, whatever is happening for them, they're able to access the community. It is safe. So it is anonymous. Again, as I talked about, that's enforced. My team is overseeing the platform 24 hours a day. And then we also have this concept of risk escalation or risk and distress escalation, which we'll talk more about as we go. But if students are struggling in a more serious way on the platform, then my team is there to step in and support them. Of course, they can also reach out to us, and we take care of what's needed. And then in terms of vibrancy, because we've been around for 18 years, we have more than 350 partner institutions, more than 3 million students with access. So people really do get the support that they need in the community. Let's see here, click, okay. So just want to break down the concept of clinical moderation for you for a minute. So peer support at scale is about giving people a community that they can engage in online on their phone. It's healthy, it's supportive, it strikes this balance of allowing people to talk about really difficult or passing mental health concerns, life difficulties, while also keeping it within sort of bounds that make sense. So people do, for example, talk about suicidality, but we don't want them talking about details. People might talk about the struggles with college or the struggles of an eating disorder or the struggles of whatever concern it might be without going into graphic detail. And so we help them do that proactively. Again, I talked about the 50 employees on the platform, and every minute of every day, we have 3 levels of clinical staffing on the platform, doing routine moderation, which is about 40% of the users, and then a shift leader who's overseeing that group of staff doing routine moderation. And then we have a staff member devoted to what I like to call off-platform case management or intensive case management, which is a tiny fraction of the users on the platform who are at risk or high distress. We call this an escalation. And when that student tips over the balance there and becomes what we call an escalation, we apply a duty of care ethic from most licensed practice around the world, where we hold on to that student until we've confirmed handoff to the next sensible service. So this is kind of what I mean by clinical moderation. And when we look back on the last 100,000 or so students that we have supported on the platform, a couple of numbers worth thinking about. And again, what I want to encourage you to do here is to think about these numbers from a population standpoint um, that works hand in hand with whatever level of one-to-one clinical services are available or other services that are being used. So about 92% of the students on the platform indicate that they have not sought support on campus. So let that sink in for a minute. More than 90% of the students on the platform are not using other campus supports. And for about 65% of them, Togetherall is their only form of mental health support. So this really reaffirms part of our mission, which is access for people who wouldn't otherwise seek the service. And it's because it's moment of need. It's not taking every moment of need and translating it into a professional interaction, saying, let's see what we can get you that provides support, validation, normalization, encouragement, new ways of thinking. And we can do that quickly and easily through a community. One of the other things that our data is really clear about is that we reach students who are historically underserved, marginalized. So about 55% of the students on the platform identify as BIPOC, which is a very, very high percentage compared to most clinical services. And a lot of the students are also non-traditional or older. And what we find is that these groups are less likely to reach out for traditional services, but more likely to engage in our platform. And then it's also really clear that we are reaching students who are at risk, either at risk from a mental health standpoint, having considered suicide, um, uh, having considered suicide in the past 6 months, or that they're at risk of thinking about dropping out. And what we find is that about 87% of the students that respond to a pop-up survey on the platform indicate that Togetherall is helpful for their mental health. And again, when you're talking about population services, you're not talking about treatment. You're talking about moment of need support. And if we're seeing that 92% of the students aren't seeking other services, and that about 90% of them are saying it's helpful for their mental health, we know we're sort of hitting our stride here in terms of implementing that population health model. One of the things I mentioned earlier is when you're applying or putting out a population health solution, one of the things is you want it to be a safe, supportive, and even therapeutic experience without being a treatment experience. And so we really wanted to dive into this question, and I'm going to reduce a fairly lengthy research project into a fairly small, into a single slide here just to convey this point. So what we did to understand the therapeutic nature of peer support was we took about 5.7 million utterances from our community. These are comments that users are making back and forth to each other. And we provided that commentary to a group called Listen. And Listen is an AI-based platform that is used to evaluate counseling sessions for whether or not the counselor is correctly implementing a particular approach, such as motivational interviewing or CBT. And so we ended up agreeing to run our community utterances through the motivational interviewing model. And to find out, is the community therapeutic? That's the first question. Could be yes, could be no. And then if it is, in what ways is it therapeutic? What we found, as is visualized on this slide, is that Togetherall shares all of the therapeutic ingredients that are measured in a motivational interviewing counseling session. The community as a whole does. And there's a large number of those therapeutic ingredients that are quite similar in proportion in a counseling session versus our community. Things like active listening, affirmations, advice, reflections, questions, those kinds of things. But where the community really shines and its emphasis is around giving information, and that's a moment of need support. And oftentimes it takes the form of self-disclosure, which is normalizing and validating. You're having this struggle, so am I. Here's how I dealt with it. Whereas counseling tends to emphasize things like the structure of the counseling session, facilitated questions, complex reflections, and so forth. And so what was really validating for us was to learn that, in fact, the community is empirically therapeutic, that it shares a lot of the ideas of counseling services, but in a moment of need when students are looking for something. And so this should provide you with a lot of confidence as well that you can implement population level services that aren't treatment, but are safe, supportive, and even therapeutic in nature. So I'm just going to wrap up here with this slide, and I see we have a couple of questions coming in. And so if there's a question lingering for you, go ahead and get it in the chat or Q&A, and we'll attend to it shortly. So just to wrap up, everybody out there who's working in mental health is coping with the challenges of the demand-supply dynamic that exists, and that dynamic has grown over the last 20 to 30 years. It has grown in part because of a help-seeking narrative, which we've all collectively encouraged. And so in response to that challenge, there's no single one-to-one clinical solution. There's lots and lots and lots of strategies, lots and lots of staffing levels, and alignment model is really key for implementing those. But in addition to that, part of my transition over to Togetherall is realizing that what we really need to begin doing is thinking about population level services, because we can't attend to 60 or 70% of the population through traditional models. So how do we build a both and no wrong door philosophy and population model that can meet people where they are? And so Togetherall is an example of this affordable, therapeutic, scalable solution that reaches students where they are in the moment of need. And oftentimes those students are hard to reach. So yeah, I think just pulling this together, and then we'll go into questions here. Population model to student mental health is really about changing the help-seeking narrative and rolling out services that can help everybody in a moment of need, but also where you as the institution and the administrator and the leader can feel confident that if a student is in crisis or in high levels of need, that they will be very carefully managed and coordinated with your services. All right, so I'm going to pause there. Hi, Elena.
Thank you so much. Hello. All right. Well, you do have a couple of questions in the Q&A, so I'm happy to read them off to you. So the first one by someone is asking, what are some ways that schools can ensure students actually use an online or virtual platform like Togetherall? In other words, what are best practices to build engagement? So I love this question because I think student engagement is something that we get asked about a lot, and it's, probably looks a little different on every campus, but just curious to get your thoughts on this.
Absolutely. Absolutely. It's one of my favorite questions. And it's such an interesting, it's just such an interesting bind where on the one hand, it feels like if we put out any service, students should just be flocking to it because it's available and they have need. So one of the things to recognize about getting students to use platforms like Togetherall is that you are fighting 20 to 30 years of precedent, which says, if you're in distress, go see a professional. So every time you're trying to convince a student to engage in next generation services, you are actually fighting that tide. And so when you're implementing a service like this, you want to take a long-term approach. I'd say 2 to 3 years, probably 3 years minimum, to say, what's the arc of our work? And then recognize that it's not just buying a service and implementing it, but it's also creating a narrative change at your institution that begins with students' arrival on campus and says, this might be the ways that you've thought about mental health in the past. This is how we think about it here. Mental health struggles are normal. Everybody who is a human being will experience anxiety, will experience stress, will experience ups and downs. And here's how you engage in first level support. So lead with those population services. Anybody who's ever done outreach or training in higher ed knows it's a broken record. Every year you go back into reminding all the new folks on campus, And it's probably going to take you 4 years before that first group of students is now the leaders on campus and helping to spread that word, and that the faculty, staff, parents, and everybody else on campus kind of gets that. So long-term approach. And if you're changing help-seeking narrative, it has to be pervasive. It can't just be on a website. It has to be events occurring at the student, the public student union or gathering places. It needs to be in one of the best places, I think, is the learning management system. We find that a single post in an LMS system about, hey, are you struggling today? There's others just like you. We can see at some institutions 200, 300, 500 students come through after one LMS post. And you think about how would a counseling operation absorb 200 to 500 students in 2 or 3 days? They could not. And so that help-seeking narrative change is across the board, but you need to be where students are in their moments of need, and that's awesome, or often at an LMS site.
That's great. Thank you for sharing that. This actually relates to a question I had that I wanted to ask about the no wrong door philosophy that you mentioned. I was hoping you could maybe dig into that a bit more, and something specific that I was curious about, especially given our audience here that not all of us are working in, a mental health counseling center. They may be curious about how they could potentially support students, maybe through this philosophy. So I was wondering if you could just talk a little bit more about that, as well as maybe talk about how or if this can expand across an institution to support mental health.
Yeah, absolutely. So the reason I really like that phrase, the sort of no wrong door, is there was a time in higher ed where if you didn't do A and then do B and then do C, you had to sort of start over. You went to the wrong door, you went to the wrong place, we're not going to help you. I think when it comes to mental health and wellness, institutions should really adopt this sort of suite of services that are available and constantly being advertised to students. And then wherever they choose on whatever day they need, they walk through a particular door. All the people behind every door know how to get to all the other ones. And so there's no wrong place to enter. If a student does a drop-in session, but they actually would really just benefit from peer support, that should be fine. If they walk into, if they're on Togetherall at 2 in the morning, but they actually need crisis services, fine, we'll get them there. And I think bringing faculty and staff and all student leaders to the table on this, part of the no wrong door assumes that everybody in the community is a support person and that they can help people get where they need to go. So investing in that training across the community and across all the different areas of service is part of it. And I think one of the consequences of the 20 or 30 years of if you're in distress, go see a professional in higher education is that sometimes people believe that if they're not a mental health professional, they can't help. I'm not paid for this. I'm not an expert in this. I can't do this. I can't do that. Peer support assumes that everybody's human and that everybody has ups and downs and everybody can provide some support in some way. And so just because a student lands with you doesn't mean you have to solve the concern. You just have to get them to the next best step.
I think that's really important. And I know we've talked a lot about today already, building trust with students as well as a sense of belonging. And I think that this ties in very nicely to that theme. I do want to make sure we get to these other questions. So the next person is asking, what are the benefits of providing a clinically moderated peer support platform versus a student assistance program, similar to an EAP that all students can use for referrals to mental health and other supports?
Yeah, it's a really good question. So an EAP, or sort of an employee assistance program that's sort of student labeled, is another form usually of one-to-one care. So, and there's lots of different versions of providing one-to-one care, and EAP is one of those. What Togetherall is online clinically moderated, so there's no one-to-one interaction. So a student comes in at whatever time is convenient for them, engages in the community, and receives support from the tens of thousands of people who are in the community. My clinical team on the back end makes sure that that experience is safe and supportive and therapeutic. And then, if needed, can get them to an EAP, or can get them to the counseling center, or can get them to local crisis resources on an as needed basis. But the vast majority of people in the community don't need those services. So the key difference is you're leading with a population support of which only a tiny percentage end up using an EAP or other service. So essentially, they can coexist. You can have an EAP and Togetherall. You can have a counseling center and Togetherall, or any version of that.
Gotcha. So very much in line with that both and approach that you were talking about. That's great.
Yep.
Awesome. All right. I think we have time for one last question. And it is, what are the potential negative impacts to students and institutions from the gap you spoke of earlier of students who say they have mental needs but aren't served traditionally? Are there any findings I can point to help convince our leadership team that we need to put money to something like Togetherall to close the gap? So I think, again, it's how do we kind of look at prioritizing and figuring out, what best proves the case for a multitude of strategies that you were talking about, kind of that range.
Yeah. So a wonderful resource I would point you back to, I'm a little bit biased, but is the Center for Collegiate Mental Health, ccmh.psu.edu. So if you want data highlighting the role of mental health in persistence and graduation, or the role of specific kinds of mental health concerns, including not mental health, real world concerns like discrimination on persistence and graduation. They've got great data there, just in general about how mental health impacts the bottom line of the university. So that's a great general resource. And then the other part that I would emphasize here is I alluded to the difference between traditional care and population. In a traditional care model, each new student referred either increases the cost of the service or dilutes the amount of service provided to everybody who uses it. In a population or wraparound kind of model, each new student referred into that service increases the sort of cost effectiveness of the contract that's in place. So a lot of times when talking with administrators about population services, it's about helping them to recognize that, oh, if I implement these wraparound services, this population model, and we take a long-term approach to changing people's help-seeking behavior, we can support huge numbers of students at a relatively low cost while reserving our specialized and fairly expensive one-to-one services for the students really, really in need of those. And so it's not an either or, it's a both and, but that financial distinction of doing both at the same time can be a really compelling argument. And I do have some graphics that might be helpful around that if folks want more information there.
Wonderful. Well, thank you so much for sharing all of these insights. We really appreciate your time. And, again, if anybody has any additional follow-up questions for Dr. Locke, we'll make sure to follow up with him via email. So we are moving on now to our next session.